Colorectal cancer, CRC, is common in the developed world and is second only to lung cancer as the leading cause of death from cancer in Europe. Although the results of treatment have shown a gradual improvement over the past 30 years, 5-year survival is still only about 50% in Ireland and the UK. Randomized trials have shown that screening for bowel cancer using guaiac-based fecal occult blood tests can reduce mortality by 16% in people offered screening and 25% in those accepting the test. As a result, and in accordance with European recommendations, many countries have introduced or are introducing bowel cancer screening programs. There are several screening models available. Along with the UK and other European Union countries, Ireland has adopted a 2-stage population-based approach. In this model, individuals who are identified as at risk by either the GFOBT or fecal immunological test, the FIT, occult blood tests, are referred for invasive colonoscopy. However, while these tests select out a population at risk for colonic cancers and adenomas, the majority of individuals who undergo colonoscopy do not have neoplasia. Recent results from the UK in a study of GFOBT positive participants showed a neoplasia detection rate of 59.5% in men and 43.2% in women, and a CRC detection rate of 10.1% following further investigations. FIT has been shown to be most sensitive and to produce higher overall positive rates compared with GFOBT. A recent study from Spain on FIT and our own pilot study showed similar neoplasia detection rates of 57% and 44% respectively. These studies have demonstrated the usefulness of occult blood tests in screening, but the relatively high rate of false positive tests is a concern. From the available data, at least 40% of people undergoing a screening colonoscopy following a positive FOBT will not have neoplasia detected, and therefore the procedure was unnecessary. In real terms, for every 1 million participants in the UK screening program, no neoplasia was found in over 6,000 colonoscopies performed. This represents a major burden on screening resources and a substantial risk for screening participants due to the invasive nature of colonoscopy and the potential for significant, albeit infrequent, adverse events. A model that reduces the negative colonoscopy rate would represent a major advantage over current strategies. One way may be to introduce a second filter test after FOBT. The test would have similar neoplasia detection rates to colonoscopy, but lower risks. If effective, the filter test would select only those individuals with neoplasia for invasive standard colonoscopy, and the number of negative colonoscopies would therefore decline, reducing the burden on endoscopy services, staff, and participants. Capsule endoscopy has been available for a number of years. Colon capsule endoscopy with PillCamp, Given Imaging Limited, Yogniam, Israel, is an innovative, non-invasive and painless ingestible capsule technique that allows exploration of the colon without the need for sedation and gas insufflation. The examination is easy to perform, can be done on an outpatient basis, and provides accurate views of the colon. Although initial reports were promising, 2 large early multi-center trials using the first-generation pill CAM showed a low sensitivity for polyps. On this basis, the new second-generation capsules were developed with improvements that included a widened viewing angle and an adaptive frame rate to allow 36 frames per second on entering the colon. Using the second-generation capsules, Spada et al. Found a sensitivity of 84% for polyps larger than 6 millimeters. Subsequent comparative studies with the colonoscopy have reported a high degree of agreement and suggest that capsule colonoscopy is useful in a variety of clinical settings, including symptomatic screening participants after incomplete colonoscopy. A recent European multicenter study reported sensitivities and specificities for larger polyps of 88% and 95% respectively. All studies reported a low complication rate for CCE and high levels of participant acceptance. Recently, the clinical indications for CCE and the reporting and workup of detected findings have been standardized and published as a European Society of Gastrointestinal Endoscopy guideline. To date, there have been no reports on the role of CCE in a FIT-based population CRC screening program. We propose that CCE could provide a screening filter test for people who have positive FIT results, thereby reducing the number of negative standard colonoscopies. It was the aim of Grainne, Holleran et al. To prospectively assess the sensitivity, specificity, and negative and positive predictive values of CCE compared with conventional optical colonoscopy in an FIT positive CRC screening cohort. They report the results in the paper entitled Colon Capsule Endoscopy as Possible Filter Test for Colonoscopy Selection in a Screening Population with Positive Fecal Immunology. Here is a summary of their study. Background and study aims. Stool tests are highly useful in colorectal cancer screening programs. However, they are not as specific as users would like and place a major burden on resources and subject a number of patients to the risks of invasive optical colonoscopy unnecessarily. Colon capsule endoscopy has the potential to reduce the need for optical colonoscopy. To date, the role of CCE in a fecal immunological test, FIT-based CRC screening program, has not been formally evaluated. The aims of this study were to assess the sensitivity, specificity, and negative and positive predictive values of CCE compared with optical colonoscopy in an FIT positive CRC screening cohort. Patients and methods. A prospective comparison study of CCE compared with optical colonoscopy was undertaken within the second round of an FIT-based BALS screening pilot program. Participants with a positive FIT result were invited to undergo both CCE and optical colonoscopy. CCE was performed on day 1 and optical colonoscopy was performed the following morning. Results. A total of 62 participants were recruited. Optical colonoscopy detected at least one polyp in 36 participants, 58%, significant lesions in 18, 29%, and cancer in 1, 2%. There was good correlation between CCE and optical colonoscopy for any lesion and for significant lesions. R is 0.62 and 0.84 respectively. The negative predictive value of CCE was high both for any polyp, 90%, and for significant lesions, 96%. Conclusions. CCE is a safe and effective means of detecting cancer and polyps in a positive FIT screening cohort. The results suggest that CCE would be a useful filter test in this situation and would reduce the number of colonoscopies performed by 71%.